hyperkalemia,
uncle come and
hypertensive
say,
emergency, cardiac
blood pressure dropping,
arrhythmias, emergency medicine,
dropping.
shock,
Then we rush down.
and
Then we
acute
stay
and
with her.
intermediate
And
long-term
then
care. This is during your
then my sister was like,
asynchronous week.
okay, you go down, change your auntie come up.
Okay, can you all please settle down
You cannot
before
go.
I start?
My aunt
I need
loves
to pass
CGH.
this over to Mr. Brandon at 5 p.m. sharp. So if you, the longer you take, the lesser time I have to cover everything.
You didn't come first, you.
I want silence before I start. Okay, so please settle down and pay attention. This revision is quite important.
When I went down,
Okay, term 2 topics
not
all
there, so I
haven't been
came up
tested
again.
before.
I saw the curtain screen.
So you know what it means. Okay, but please note your final exam covers both term 1 and term 2 topics. It is not just term 2. Term 1 will also be tested. Okay, so we go to the week 11, renal emergencies. So for farm, the 3 most important medications that you need to focus on is the one in the red box. Sodium, polystyrene, sulfonate, resonium. You need to know how to spell. And the whole thing, if you only write down resonium, I'm sorry, no marks. You must write down sodium, polystyrene, sulfonate. Then you get the marks. Okay? So this is medication number 1. Medication number 2 is insulin regular, which is atropine and dextrose. Okay, for hyperkalemia. And the third medication you must know is IV calcium gluconate. So these 3 medications are very important for this topic. So the first medication is the resonium, sodium polystyrene sulfonate. Okay, so what is important here mainly is how to spell. That one is a challenge for you all already. If you can spell it everything correctly, half of the challenge is won. Okay? You need to know the MOA, mechanism of action. How does it work? So you see the intestine there? It works in the large intestine. So how does it work in the large intestine? It exchanges sodium ion for potassium. So the name itself, sodium polystyrene sulfonate, it has sodium. So when you reach your large intestine, you will do an exchange. So it gives out sodium, it takes in potassium, and it removes the potassium in the stool. Okay, so it is a sodium-potassium exchanger. So it exchanges sodium ion for potassium in the large intestine. Okay, the place that it happened is important. So the keyword, exchange sodium ion for potassium in the large intestine enhances the excretion of potassium. This is how it helps to lower hyperkalemia. Okay, so the MOA is important. Also, you need to see the one in red color. This will cause a reduction in total body potassium. What does it mean? It means actually the potassium will get out from your body through the stool. So in the whole body, the potassium level will decrease. So there's a reduction in total body potassium. This is very important because the other medication, the second medication, the insulin regular, no effect on total body potassium. The potassium is still in the body. It's just that insulin is able to shift potassium into cells. Okay, the mechanism of action of insulin, how it treats hyperkalemia, is that it shifts potassium into the cell within 20 to 30 minutes. That's very fast. But there's no effect on total body potassium. So all those are keywords. Okay, MOA, keywords. And why do we give dextrose? This is logical because patient got hyperkalemia, we give insulin. Insulin also causes blood sugar to go down, right? So we want to prevent hypoglycemia. That's why we give dextrose. Okay? So if you remember my first revision over MS Teams, I say that insulin has 2 indications. Please don't get confused. Insulin can be used for hyperglycemia. This is a term 1 topic. Insulin can also be used for hyperkalemia, high potassium. This is a term 2 topic. Please read the scenario carefully. Determine the insulin is used for what. Important, please read the scenario carefully. Determine whether the insulin is it used for hyperglycemia or hyperkalemia.
Don't give me the wrong
Because CJ
answer.
was Toa Payoh Hospital.
If it is
They
used for
got Toa Payoh
hyperkalemia, but you
SGH.
give me all the hyperglycemia MOA,
So they love-
hyperglycemia side
I'm
effects,
love CJ.
zero, everything
Both die in
zero.
hospital.
So please read the scenario. Is this a hyperglycemia problem or is this a hyperkalemia problem? Because insulin can use for both indications. Okay, so if it's a hyperkalemia problem, you see the scenario, potassium very high. Okay, potassium very high is a hyperkalemia problem. So how insulin works? Shift potassium into cells within 20 to 30 minutes, no effect on total body potassium. That is the keyword lah. If potassium normal, blood sugar very high, it's a hyperglycemia problem, right? So the MOA is different. So do you remember the MOA for hyperglycemia?
No. Born dying.
That one is a term one. We go to term one. I have it here. Yes. Term one. Where is it? Term one over the MS Teams. I got mentioned also. This is the hyperglycemia MOA for insulin. Increase glucose uptake and utilization by skeletal muscle and cells. Inhibit endogenous glucose production by the liver. Inhibits lipolysis, ketogenesis, and glucagon secretion for DKA. Okay, so this is the MOA for hyperglycemia. The MOA for hyperkalemia is different. Shift potassium into the cells within 20 to 30 minutes, no effect on total body potassium. So the answer you give me depends on what is the indication for insulin in the scenario. Please read the scenario carefully. Okay, once you interpret wrongly only, your answer is all wrong. Okay, because insulin can use for two things. So please be very careful. Okay, so insulin usually given with dextrose. However, if the patient glucose is already very high, you don't give dextrose anymore. Okay, if you check that glucose is already very high, dextrose no need to be given if the patient already got severe hyperglycemia. Okay, if the patient, the glucose is normal, then you need to give dextrose because otherwise insulin will cause the glucose to drop and the patient will go into hypoglycemia. Can I understand so far? So sodium polystyrene sulfonate and this insulin regular, which is atropine. Okay, both are used for hyperkalemia. What's this? Okay. So if let's say you use these medications, what are your nursing considerations? Of course, you need to monitor potassium level closely. This one is given, okay, because they lower potassium, all right, and can cause hypokalemia. If you lower too fast, it can cause hypokalemia. Okay, so you need to monitor your serum potassium. Okay, and adverse effects because it can cause hypokalemia. So what do you need to monitor? Monitor for, just give one example, muscle weakness. Okay, muscle weakness is the most common sign of hypokalemia. If the patient got muscle weakness, it can indicate hypokalemia. You need to inform the doctor to check the potassium. Okay. Sodium polystyrene sulfonate, because it also has sodium and all that, it can also affect the electrolytes such as sodium because the medicine itself has sodium. And if you give dextrose, you need to monitor the blood glucose because the dextrose can cause the blood glucose to go up very high. So again, if the blood glucose is already very high, you don't need to give the dextrose together with the insulin. Okay? Okay, so the third medication, the third important medication is this one, the calcium gluconate. So this one you need to understand. If you don't understand this, you won't be able to understand the mechanism of action. So what happened is that hyperkalemia, high potassium, is very dangerous for the heart. The heart can go into arrhythmia. Okay, in high potassium, the heart can go into arrhythmia because what happened is that the resting membrane potential, okay, is increased in hyperkalemia. So you see this distance between the resting membrane potential and the TP, that is the threshold potential. Once you exceed the threshold potential, you will generate an electrical activity. So in hyperkalemia, the resting membrane potential is very near the threshold potential. This means it is very easy for electrical activity to happen. When it's very easy, then you will keep on generating a lot of electrical activity. That is when the heart can go into arrhythmia. Okay, that's why hyperkalemia is very dangerous for the heart. So what happens is that we will need to do something about this. So what do? We give calcium gluconate. Okay, calcium gluconate will further increase the threshold potential. So basically, you see this is the resting membrane potential. In hyperkalemia, it is elevated. So at first, it's very close to the threshold. It's very close to the threshold potential. I don't have a mark. But anyway, it's very close to the threshold potential. So that one is quite dangerous, because it's very close, it's very easy to generate an action potential. So if you keep on generating action potential, then that will be arrhythmia. So what calcium gluconate can do is that it can increase the threshold potential, the dotted line. It makes it further away from the resting membrane potential. So it's not so easy to generate electrical activity. When it's not so easy to generate electrical activity, you won't be having arrhythmias. Not so easy to have arrhythmias. Okay? So calcium gluconate increases the threshold potential. That is how it works, to prevent the cardiac toxicity from hyperkalemia. Okay, so this one is a famous question now. Okay, so calcium gluconate, if I ask you, does calcium gluconate affect potassium level? Yes or no? Yes or no? No, okay? Calcium gluconate does not affect potassium level at all. What it does is that it just stabilizes the heart. The only medicine that affects the potassium level is your sodium polystyrene sulfonate and your insulin. These two will affect the potassium level. Sodium polystyrene sulfonate will get rid of the potassium from the feces out of your body, so it will reduce total body potassium. Insulin will shift potassium from the blood into the cells, so it will temporarily reduce the potassium in the blood. But the potassium is still in your body, so there's no effect on total body potassium. But calcium gluconate does not touch the potassium at all. It doesn't have any effect on the potassium level. So what it does, is that it prevents cardiac toxicity in the presence of hyperkalemia. That is the function, that is the reason why we give calcium gluconate, is to prevent cardiac toxicity in the presence of hyperkalemia. If you don't do this, the hyperkalemia patient will go into arrhythmia and will die. Okay? So the mechanism of action of calcium gluconate is that it regulates action potential threshold and prevents cardiac toxicity in the presence of hyperkalemia. So if the question asks for MOA of calcium gluconate, this one, the one in the red box, MOA, just that one. Regulates action potential threshold, preventing cardiac toxicity in the presence of hyperkalemia. Okay? Yeah, this one is important. Okay, so the thing is that with all electrolyte infusion, you need to administer slowly. Okay, when you administer calcium gluconate, it has to be slowly, cannot be too fast. All electrolytes have to administer slowly. So in this case, you cannot exceed 200 milligrams per minute. Okay? Yeah, so run it slowly, not too fast. Okay, and because you are trying to prevent cardiac toxicity, right? So when you run the calcium infusion, you need to check the ECG. Okay, check the ECG and monitor the calcium level. Because you give too much calcium, patient can go into hypercalcemia. Monitor the ECG is to monitor for any arrhythmia. Okay, so these are some of the nursing considerations. Okay, monitor for extravasation. Extravasation is basically the medicine leaking out of the blood vessels, so it will cause irritation. So any extravasation, you need to inform the doctor. And monitor for signs of hypercalcemia. Because you're giving calcium, patient can go into hypercalcemia. So the side effects is almost the same like hypokalemia, weakness, confusion, all these. Okay, so these are the nesting considerations. Okay, week 12. Week 12 is a presentation week. So we didn't go through in class, okay, but week 12 is on hypertensive emergency. Mainly you will learn this medication called the sodium nitroprusside. Okay, sodium nitroprusside. So sodium nitroprusside is basically to lower the blood pressure. Okay, in hypertensive emergency. This is week 12 topic already, week 11 finished already. So week 12 topic, sodium nitroprusside. The important things to know about sodium nitroprusside will be the side effect. Okay, nitroglycerin also can lower blood pressure, but sodium nitroprusside is more effective in lowering the blood pressure, but it has other side effects. Example, in your lecture notes, there is this blue man here. Have you seen any patient look like this before? No, this one very serious already. This one is from I think one of the X-Men character, if I'm not mistaken. So sodium nitroprusside can cause this rare side effect called methemoglobinemia. Yeah, the name is like that. I cannot do anything about the name. So methemoglobinemia is a side effect of sodium nitroprusside. Special side effect. Okay? So there is an antidote for this condition. So basically, if the patient has this condition, the patient will turn blue, cyanosis, turn blue. So there's an antidote for this condition. The antidote is called methylene blue. Okay, so you turn blue, we give you methylene blue. Okay, this is the antidote for methemoglobinemia. Another thing that sodium nitroprusside can cause, okay, is cyanide toxicity. This is important, cyanide toxicity. Nowadays, people like to kill other people using cyanide. So you better know what is the antidote for cyanide toxicity in case if you accidentally drink someone's coffee that contains cyanide, you know how to treat yourself. So sodium nitroprusside also can cause cyanide toxicity. Cyanide is a deadly poison. Deadly poison. Okay, so you definitely die. So what is the antidote? Antidote is sodium nitrite or sodium thiosulfate. These are the antidote for cyanide toxicity. It is contained in the cyanide antidote kit. Okay? These are important or not?
Not important.
I never said it. These are important because recently got this case, right? You all go Bangkok, right? All like to go Bangkok, right? This case just recently happened in Bangkok. Order all the food, all the coffee, all the tea, then one of them put in the cyanide. All died. Yeah, so nowadays, it seems that cyanide is quite easy to get in Bangkok. So please know that every time you go Bangkok, you carry an antidote. What is the antidote? Sodium nitrite, sodium thiosulfate. This is the antidote for cyanide toxicity. Then you can save yourself. Otherwise, you'll be lying down on the room. What happened to these people? Okay? So important. Up to your interpretation. What's this for? It's part of your syllabus. Okay, so nursing consideration for sodium nitroprusside. Any this is if the person has any hypersensitivity, that means allergy, we cannot give already. Then same as your nitroglycerin, you know if systolic blood pressure is below 90, we cannot give. It's a contraindication. If the patient blood pressure is low, you cannot give. Okay? So use an infusion pump, and sodium nitroprusside must dilute with dextrose 5%. Cannot use normal saline, and wrap with aluminium foil because it is light sensitive. Okay, you must wrap the sodium nitroprusside aluminium foil. It is light sensitive. If it gets to the light, it will degrade. Okay, so how to monitor therapeutic effects? This is something to bring down blood pressure. So you need to monitor blood pressure continuously via an intra-arterial line. Okay, and so for For nitroprusside, there are two extra things over there. It can cause methemoglobinemia. The antidote is methylene blue. Okay, it can also cause cyanide toxicity. The antidote is the cyanide antidote kit, but you must tell me what is it, sodium nitrite, sodium thiosulfate. Okay, so this is week 12. Okay, I'm going quite fast because I actually don't have enough time. The more important one is in the later weeks. Week 13, anti-arrhythmic medication. Week 13, you only need to focus on 4 medication. Only 4 medication: adrenaline, amiodarone, lignocaine, adenosine. The rest all no need to know. Only the one in the red box. Okay, adrenaline, amiodarone, lignocaine, adenosine. Okay, MOA very important. MOA, you focus on this one. This is the lignocaine. You need to know that lignocaine is a sodium channel blocker. Yeah. Lignocaine is a sodium channel blocker, so it blocks sodium channel. And amiodarone is a potassium channel blocker. Okay, potassium channel blocker. If you know this, at least you can get 1 mark each already, because the pharm class is correct. You don't need to understand this complicated diagram if you don't want to. Okay, but you need to know lignocaine is a sodium channel blocker. It inhibits sodium influx. Okay, pay special attention to the word. This one is influx. This word is what? Efflux. What is the difference between influx and efflux? One go in, one come out. So the go in one is which one? Influx. Efflux means go out. So if your word is wrong, you get 0. If let's say you tell me that lignocaine is a sodium channel blocker, inhibits sodium efflux, wrong, because the correct word is influx. Okay, same. This one you must tell me is inhibits potassium efflux, because this is potassium going out of the cell. So that word matters, influx versus efflux. Please don't give me the wrong word. Okay, this phase, this one going upwards is called depolarization. This one coming downwards is called repolarization. You must also give me the correct term. If over here you say repolarization, wrong. This is depolarization. This is repolarization. So the tricky part is here. Okay? Okay, the next important one is this table. This time my star come out already. MOA, the one that you all love the most. Okay? So what is the MOA for lignocaine? You see? Inhibits sodium from entering into the cell. This is sodium influx, right? So reduces depolarization, reduces conduction velocity. Amiodarone, potassium channel blocker, inhibits potassium efflux. Efflux, EFFLUX. So this delays repolarization and prolongs the refractory period. These are all keywords on the MOA. Okay, adenosine, forget about it. Adrenaline, very important. Adrenaline, you need to tell me it stimulates what receptor? What receptor? Very important. Okay, please don't give me symbol like this in exam. Must spell out. Alpha, ALPHA. Beta, BETA. Don't give me symbol. You give me symbol like this, you will get minus marks because of abbreviation. So adrenaline, you need to know it's an adrenergic agonist. It stimulates alpha 1, beta 1, and beta 2. Okay? So stimulate alpha 1, what will happen? This one you must know. Stimulate alpha 1, what will happen? It will cause vasoconstriction. Stimulate beta 1. Beta 1 is in the heart, so it will cause increased heart rate. It will cause increased cardiac contractibility. Stimulate beta-2, it will cause bronchodilation. The receptor and the clinical effect for adrenaline, you must know. Okay, as well as the MOA for lignocaine and amiodarone. Okay, so the indication, what is used for, just remember, if you see a flat line, flat ECG, asystole, flat line is asystole, you cannot use lignocaine, you cannot use amiodarone. Asystole, you can only use adrenaline. Because lignocaine and amiodarone, you need electrical activity in order to use the drug. So if you see a flat line, asystole, only adrenaline. As long as your ECG has something, some kind of shape, whether it's ventricular fibrillation, whether it's ventricular tachycardia, you can use lignocaine, you can use amiodarone, you can also use adrenaline. But if asystole, flat line, only adrenaline. You cannot use lignocaine and amiodarone. So in ventricular fibrillation, ventricular tachycardia, all kinds of abnormalities in the ECG, sometimes doctor will use both, either amiodarone adrenaline or lignocaine adrenaline. All right? So adrenaline, this one is like the insulin. Adrenaline also has multiple indications. So in week 13, you actually learn adrenaline can be used for cardiac arrhythmia. It can also be used for asystole. In week 15, in shock, you should also know that adrenaline can be used for anaphylactic shock. The mechanism of action is the same. Because it stimulates the same receptor, it has the same clinical effect. Okay? So adrenaline, depending on the question, what is the adrenaline used for? Is it used for arrhythmia? Or is it used for anaphylactic shock? Read the scenario carefully. Okay, because it can be used for two things. Okay? Okay, this table very important. You know what? Why we don't record this, right? You know what it's mean by very important. Okay, this table is very important. This is what? Side effects of amiodarone. So amiodarone has many side effects. Okay, you start from the top of your body. The neck. What is in the neck? What is at the neck here? Thyroid gland. Okay, thyroid gland. So amiodarone can have the side effect on the thyroid gland. It can cause hypo or hyperthyroidism. Either one, we don't know. Okay, it can cause hypothyroid, it can cause hyperthyroid. So what is your nursing consideration? You need to monitor thyroid function tests. Logical, right? If it can cause hypothyroid, hyperthyroid, I need to monitor thyroid function tests. When? Before initiation and periodically. Before I start the medication and regularly, I need to monitor thyroid function tests. Then you go down, from your neck, you go down to your lung. It can cause pulmonary toxicity. So I need to monitor pulmonary function tests and chest x-ray. Okay, you go down some more, liver can cause liver toxicity. So I need to monitor liver function tests. Okay, and look out for elevated liver enzyme. If you just say monitor liver function tests, you only get 0.5 marks. Because you never tell me what you are looking out for. So you must tell me monitor liver function test to look out for elevated liver enzyme or elevated liver function test. Then you get the full one. Okay? And the last one is over the whole body. It can cause skin rash, sunburn. So monitor patient for skin rash or sunburn. Or you can put down also advise patient to use sunblock when going out of the house. As long as it's logical, we will accept your answer. Okay? So these are the side effects of amiodarone. Yes. What question? Huh?
How to get sunburn infection in the body?
This one, okay, this is, some patients take oral amiodarone, means they are discharged with amiodarone, they take it long term. So they actually take it at home, tablet. So that one they can get sunburn. Yeah, some hospital also the bed next to the window, right? You know lah, I don't know which hospital lah, but some hospital I go, the patient next to the window, every time under the sun. Also can get sunburn. Possible, not impossible. Okay, this one also very important. Adrenaline, I think you also learn in your NSL, need to dilute, huh? But which one need to dilute? Open your eye in the exam, please see the concentration of the adrenaline given to you. If the adrenaline concentration is 1 milligram per 1 ml, you need to dilute. If the adrenaline concentration is already 1 milligram per 10 ml, please don't tell me dilute, already diluted. Okay, so open your eye, see what is the concentration of the adrenaline given in the exam. If it is the 1 milligram per 1 ml, how to dilute? You need to dilute 1 milligram per 1 ml adrenaline with 9 ml of normal saline, or you can say sodium chloride 0.9%, to make up a total of 10 ml solution. We need to dilute first. Okay? So after dilution, the concentration is 1 milligram per 10 ml. Or if you don't want to write this, you can also write like this, 1 in 10,000. Okay, so please look whether the adrenaline in your exam question, has it been diluted or has it not been diluted. If it's not been diluted, you need to dilute 9 ml of normal saline. Okay? Yeah, this one I think same as your NSL also. Need to dilute the adrenaline. Okay, week 14. Week 14 is emergency medicine. Emergency medicine for farm, not so important. The important one is the NS part. You must know your PHA category very well. The medicine for week 14 for farm is a repetition of other weeks. Okay? So what is important? You must know this. This one important. This is referring to which medication? Which medication has impact on all these receptors? Adrenaline. Okay, adrenaline. Adrenaline impacts these receptors. So you must know, stimulate alpha 1. Alpha 1 is where? Blood vessel. What is the clinical effect? Vasoconstriction. Stimulate beta 1. Where is beta 1? Heart. What is the clinical effect? Increased heart rate, increased myocardial contraction, or increased force of contraction, or increased myocardial contractibility. All mean the same thing. Okay, stimulate beta 2. Where is beta 2? It's in the lung. What will happen? Bronchodilation. Yeah, okay. So this one is adrenaline. Okay, so this table you must know. Okay, so over here adrenaline. So you can see adrenaline basically MOA over there. If I say I want to know what is the MOA of adrenaline. Adrenaline stimulates alpha 1, beta 1, and beta 2 adrenergic receptor. Please don't give me symbol. Please spell out. Please spell out. Don't be lazy. Please spell out ALPHA BETA. If you give me symbol, you will be minus 0.5 marks. So next part, what happened? If I stimulate alpha 1, it will cause vasoconstriction. Stimulate beta 1, increased heart rate, increased cardiac contractibility. Stimulate beta 2, it will cause bronchodilation. So these are the mechanism of action of adrenaline, which we cover again in week 14. So you see, adrenaline week 13 got, week 14 also got, week 15 also got. So you must know this medication. Okay? Again, week 14 also come out the same question again, ask you about dilution. Okay, so this one, I have one more picture. Oh, okay. This one, 1 mg per 1 ml, dilute or no dilute? Dilute. This one, 1 mg per 10 ml, dilute or no dilute? This one, no dilute already. So you dilute this one only. you add how much? 9 ml of what? Normal saline. If you say dextrose 5%, wrong. 9 ml of normal saline to make up a total of 10 ml solution. So the final dilution is 1 mg per 10 ml. Okay, another thing we learned in week 14 is the emergency kit. How to handle emergency kit. If you go to the ward, you see the emergency kit, there is a seal. There is a seal. If the seal is broken, can you still use the emergency kit? Cannot. You cannot be sure what happened inside. If the seal is broken, immediately bring back to pharmacy. You need to exchange with a new emergency kit. Okay? If the drugs in the emergency kit has a short expiry date, you need to write the short expiry date outside the box and pay attention. Once the expiry date has reached, you also bring back the whole emergency kit, exchange with the pharmacy, one-to-one exchange. So you need to know these principles of the emergency kit. Can you lock the emergency kit in the cabinet? Then let your boss in charge keep the key. Can or not? Why cannot? Yeah, it's for emergency, right? If let's say you lock it up and then your boss go for lunch, how? Then emergency happen during lunchtime, then how to open? So cannot, emergency kit cannot be locked, but there is a seal. This seal is very easily broken. You just twist only, you can break it already. Okay? After you break it, you can immediately use whatever is inside the emergency kit. Okay, now come to the most difficult topic. Week 15, shock. Which shock will come out? You don't ask me, you ask Mr. Brandon. I don't know which shock will come out. Pharmaco, the shock only got what? Only got a few medication, right? Dopamine, dobutamine, adrenaline, noradrenaline, crystalloid, colloid. So for the medication, it can only cover a few kinds of shock. Hypovolemic, cardiogenic, anaphylactic. Yeah, septic shock, so we never really teach you antibiotics, so not really septic shock. Neurogenic shock, no medication, very easy. So medication only can cover your hypovolemic shock, cardiogenic shock, and anaphylactic shock. Okay? But here, the shock, why it's a bit difficult for pharm is that you need to know the differences and the similarities between the medication. Okay, so first one, crystalloid and colloid. So when a person is having shock, you need to do fluid resuscitation. Agree? So fluid resuscitation is to treat the low blood pressure and volume. We will use two kinds of fluid. One is crystalloid, another one is colloid. Okay, crystalloid is all water soluble. So crystalloid, if you look at the solution, it is colorless because everything is dissolved in the solution. Colloid, if you look at the solution, it is cloudy. Cloudy, yeah? Why? Because the molecules in a colloid is not dissolved. It is suspended in the solution. It's floating inside there. And it's large molecules, large protein molecule. So colloid solution always is cloudy. If it is a clear solution, it is a crystalloid. Okay? So when we want to give crystalloid, okay, you need to monitor a few things. First of all, this is an IV injection, so inflammation and irritation, of course, with every IV injection. And you are giving the patient fluid. So when you give the patient fluid, you always need to monitor intake output. Okay, intake output, look out for signs of fluid overload. Okay, patients with heart failure or kidney failure is a high chance for fluid overload. Especially when you give fluids, they can always go into fluid overload. Okay? And you're giving fluids, you also need to monitor electrolyte, especially the sodium and potassium. So these are the side effects, the nursing consideration for the side effects. What else? Yeah. Okay. So for colloids, okay, colloids, these are some of the examples of colloids. So colloid is actually protein, which is suspended in the solution. You can see the colloid solution, it is cloudy, it's not clear. Okay, so example like albumin, dextran, gelofuscin, these are all colloid. So if these names come out in the exam, you need to know that it is a colloid. Okay, it is a colloid. Albumin is a protein. Dextran, large molecule. Gelofuscin is a protein. So all these are very big molecules. They are colloid. Okay, this one got star. Okay, adrenaline versus noradrenaline. So you need to know this is like cousin. Okay, the name is almost the same, but it is not the same. Okay, so what is the difference? So you need to know that adrenaline stimulate what? Just now you said alpha 1, beta 1, beta 2, right? Okay, so you lead to vasoconstriction, increased heart rate, increased cardiac contraction, and bronchodilation. So what is the difference with adrenaline and noradrenaline? Sorry. Okay, noradrenaline also stimulate alpha 1, also stimulate beta 1. But the big difference is that, you say write down the big difference, noradrenaline does not stimulate beta 2. Okay? Noradrenaline does not stimulate beta 2 receptor. Okay, noradrenaline does not stimulate beta 2 receptor, so it doesn't cause any bronchodilation. So if it doesn't cause any bronchodilation, noradrenaline cannot be used in asthma, it cannot be used in anaphylactic shock. Cannot, because anaphylactic shock, when you see anaphylactic shock, how is the patient like? Wheezing, breathing difficulty, eyes swollen. Okay, so because of the breathing difficulty, you need to give a medication for bronchodilation, that will be adrenaline. Because noradrenaline does not stimulate beta 2, it cannot cause bronchodilation. That is the first difference.
Anaphylactic shock.
The second difference is that noradrenaline's effect on alpha 1 is very strong. Okay, noradrenaline stimulates alpha 1 very, very strongly. So this will affect what kind of clinical effect? Vasoconstriction, correct. Because if you stimulate alpha 1, you cause vasoconstriction. So noradrenaline can cause very, very strong vasoconstriction. Okay, very, very strong vasoconstriction. So why is this important? It's in the side effects. Okay, so you can see over here, noradrenaline, both they put down here peripheral and gastrointestinal ischemia. But noradrenaline is much stronger in causing peripheral and gastrointestinal ischemia. So what is this? What is peripheral ischemia? Yeah. Yeah, correct. Okay, my star student, I think this one can get 100 marks already. Yeah, 100 marks already. Okay. So, yes, okay, peripheral ischemia is like this.
Oh my God.
So these are peripheral ischemia. Where it happened in the periphery. So that means your fingers and your legs. Okay, because noradrenaline can cause, it stimulates alpha 1 very, very strongly. It causes your blood vessels in your hands and also your leg to vasoconstrict. Become very, very small. So what happened? Not enough blood supply to your fingers and your leg. Not enough blood supply, what happened? They start to die lah. Okay, because not enough oxygen, not enough nutrients, your fingers will start to die. So you see your finger turn black. Your toe also turn black. So this is called peripheral ischemia because the noradrenaline vasoconstrictive effect is very strong. Adrenaline doesn't really cause this. Okay, adrenaline doesn't really cause this. Another is gastrointestinal, so it can also cause the gastrointestinal, the intestines to start dying like this because it will vasoconstrict the blood supply to the intestine. Okay, so what are the two differences between adrenaline and non-adrenaline? Difference number one is adrenaline does not stimulate beta 2 receptor, so it cannot be used in asthma or anaphylactic shock. Correct. That's the first difference. Second difference is that what's the second difference? Yes, it stimulates alpha 1 very strongly, so its vasoconstrictive effects is very strong. So noradrenaline will cause the side effect of peripheral ischemia or gastrointestinal ischemia. Okay? That is the first cousin pair. I'm almost ending already. I think this is my one. Okay. The second cousin pair, dopamine and dobutamine. This one also you must know, dopamine and dobutamine. Okay? So dopamine and dobutamine both will stimulate beta 1 receptor, the green box. Okay? Dopamine and dobutamine both will stimulate beta 1 receptor. Okay? But the difference is dopamine stimulates alpha 1 and dobutamine stimulates beta 2. That is in the red box. That's the difference. So what happens is that this alpha 1 and beta 2 is in the blood vessel. Okay, I know we know beta 2 is in the lung, but this beta 2 that we are referring to is in the blood vessel. Okay, blood vessel. So if dopamine and dobutamine stimulate beta 1 is in the heart, right? So it will cause increased heart rate and increased cardiac contractibility. But the difference is in the red box. Okay? Dopamine stimulates alpha 1 in the blood vessel, it will cause vasoconstriction. But dobutamine stimulates beta 2 in the blood vessel, it will cause vasodilation. This is the main difference. Okay, this is the main difference. So you see in your tutorial, okay, this is from your tutorial worksheet. Tutorial worksheet, week 15 tutorial worksheet. Both dobutamine and dopamine stimulate beta 1 receptor. Okay, so it will cause positive inotropic effect, which means increased heart rate, increased force of contraction. But dopamine stimulates alpha 1 receptor, it causes vasoconstriction, but dobutamine stimulates beta 2 receptor and causes vasodilation. This is the only difference. So what happens is that you imagine if you give the patient dopamine, the heart is contracting faster and stronger. But at the same time, the vessels that's coming out from the heart is also vasoconstriction. So it's very hard to pump the blood out of the heart, right? Correct or not? Because you pump faster and stronger, but the blood vessel also constrict. So it's a lot of work for the heart to pump the blood out of the heart. But for dobutamine, although dobutamine makes the heart pump faster and stronger, there is also vasodilation. So it's actually easier for the heart to pump the blood out. This is the main difference now. So, clinically, if the patient has a very low systolic blood pressure, okay, they are all used in cardiogenic shock, dopamine and dobutamine. If the patient has very low systolic blood pressure, less than 80, we will use dopamine first. Because dopamine effect to increase blood pressure is much stronger. Because it can make the heart pump faster and stronger, it also causes vasoconstriction, so it can cause the blood pressure to go up even higher. So in very low blood pressure, systolic blood pressure less than 80, we will use dopamine first. But when the systolic blood pressure is higher than 80, we can use dobutamine. Okay, because dobutamine, the blood vessels will vasodilate, so it's actually easier to pump the blood out. There is actually less work on the heart. It's gentler on the heart. Dobutamine is gentler on the heart. This week 15 one, I don't deny, is the most difficult one among all your weeks. Okay, which is why we put close to exam, so that you study, you remember, you go for exam, you forget about it. I cannot forget, you will definitely need to use it in your PRCP. Definitely, right? Okay? Calculation. Calculation is very standard. Very, very standard. The question is always like this. The problem with dobutamine is a lot of people confuse with the formula. Actually, the formula very easy. You just put in the body weight. Okay, so you see like this. What stock is 250 mg per 20 ml? The formula is body weight times 3 mg. You dilute in total 50 ml of dextrose. The body weight is given for the patient, 60 kg. So what is the volume to be withdrawn? So very easy, 60 kg, how many mg I need? 60 times 3, I need 180 mg of the dobutamine. 250 mg is found in 20 mils. 180 mg, how many mils? You do the proportion, you get 14.4 mils. So you need to withdraw 14.4 mils. This kind of calculation can give you 2 marks. If you don't know how to do this, 2 marks bye-bye. Okay? This one 2 marks. The next one is always ask you on the infusion rate in mils per hour. Also very standard, 3 steps you get your answer. Step 1, multiply by the body weight of the patient. So 5 mcg per kg per minute, multiply by 60 kg, 300 mcg per minute. Next, you convert the mcg per minute to mg per hour. Also very standard, you multiply by 60 over 1000. You get the answer in mg per hour. The last step, you calculate mils per hour. So based on proportion, body weight times 3 mg, right? So 60 kg times 3 mg, you need to put into 50 mils of solution. So 18 mg, how many mils? You do the proportion, it's a 5 mils per hour. Step 1, step 2, step 3. All your INS 3.1 calculation is the same. Okay, it's the same. You follow step 1, step 2, step 3, you will get the answer. Yes, sure, very sure. This one also 2 marks. Yeah, this one the correct answer and unit give you 1 mark. The correct working give you another 1 mark. So you get total is 2 marks. Okay, the previous one is also 2 marks. Correct answer and unit 1 mark. Correct working 1 mark. So this calculation question is found in your tutorial worksheet and also found in your exam revision worksheet. So please do it. Okay, your tutors will go through both exam revision paper 1 and 2 this week in class. Alright? Okay, last one ready. I'm running out of time. Okay, last one. Nursing consideration for IV dobutamine. Okay, this one very important. So basically, it is what you need to look out for when you are giving dobutamine. Remember, dobutamine is a medication that is used to make the heart pump faster, stronger. It affects blood pressure. So these are the things you need to monitor. Number 1, you must administer using infusion pump. Cannot use your hand. Cannot use your hand because not precise. The reason you use infusion pump is because you can allow a precise flow rate management. Second thing, this medicine affects your blood pressure. You must monitor your blood pressure continuously. So how to monitor blood pressure continuously? Can you use the normal blood pressure cuff? That is not continuous. That one you must press the button, only then you know what is the blood pressure. You never press, you don't know. So if you want continuous blood pressure monitoring, it's through the intra-arterial line or the central venous pressure. Intra-arterial means there's a probe that go into the blood vessel. Okay, so we need precise measurements. Okay, for accurate titration of the dosage. So you give me either one now. You don't give me all 3. Just give me one explanation, one rationale will be enough. Rationale means why are you doing that? Okay. Third thing, monitor electrocardiogram continuously because we want to detect cardiac arrhythmia. Because dobutamine make your heart pump very fast, right? When pump very fast, the risk of arrhythmia go up. Okay, so we need to monitor cardiac arrhythmia. Monitor for extravasation. Okay, extravasation means the blood, the medicine can leak out the blood vessel. Okay, so when it leaks out the blood vessel, it will cause irritation at the site of infusion. So we need to monitor. Monitor potassium. Dopamine can cause hypokalemia. Monitor for chest pain. Because your heart is pumping faster, it can increase myocardial oxygen demand. So chest pain may be impossible. So these are the 6 nursing considerations when you are using dopamine. Okay, last one, I already mentioned adrenaline. So here you can see a picture of an EpiPen. So EpiPen is used emergency for anaphylactic shock. So adrenaline can be used for anaphylactic shock. It stimulates alpha-1, it causes vasoconstriction, so it increases the blood pressure. During anaphylactic shock, your blood pressure will drop. Okay, so adrenaline stimulates alpha-1, increases the blood pressure. Importantly, it also stimulates beta-2, so it causes bronchodilation. So it will relieve all the wheezing. Okay? And also it will inhibit the release of the inflammatory mediators such as histamine. So that is why adrenaline is used for anaphylactic shock. But adrenaline is not used for, but noradrenaline is not used for anaphylactic shock. Noradrenaline is not used, but adrenaline is used for anaphylactic shock. Okay, that's my last slide. This one you go through it, that one you go through. You want to go, you have yours? Okay. Okay, so that is the end actually for the revision. So all these slides we will actually post into Brightspace after tomorrow. Now we wait for the second round to finish, then we'll post it tomorrow. So later, Mr. Brandon will go through the marking standards with you all, what we expect in your paper. Okay, what we expect in your paper, you must answer according to a certain standard. And remember to take your attendance later also, by scanning the QR code. Okay, I will pass over to Mr. Brandon. Okay, do you have any questions? Any burning question for the